Oh, I love this. Soundtrack for education.
I have faith in all you do. Just call my name and I'll be there. I'll be there to comfort you, build my world of dreams around you. I'm so glad I found you, yeah. I'll be there with a love so strong. I'll be your strength. You know I keep holding on. Let me fill your heart with joy and laughter. Togetherness with all I'm after. Just call my name and I'll be there. I'll be there to protect you. With an unselfish love that respects you. Just call my name.
All right, thank you everyone. Thank you, Neptali. Um, welcome and have a good afternoon, everybody. Welcome to Caregiving in the Spotlight, an opportunity to reimagine. My name is Daniel Lau. I am with Northern California Grantmakers. I use he, him, and his pronouns, and I'm so excited to be able to welcome you to today's program and today's event with our speakers and moderator. I have a few housekeeping reminders that I'd like to share before we get started. So please take a moment to rename yourselves or update your name. What we'd love to do in terms of building community and just being aware of who's joining us today is to have everybody's name and their organization affiliation recognized in their Zoom profile. So please take a moment to do so if that's not already updated already. Today's session is being recorded and will be made available afterwards. And any resources or materials that are mentioned by the speakers or shared through the chat will be also provided after today's session in a follow-up message. Please feel free to use the chat. If you're having any technical issues, we can help address those. And also as the speakers are presenting their content and information, if you have questions, there will be a Q&A portion following each of their remarks, and the chat feature will be the best way to communicate those. And yeah, just want to, and also want to send a special thanks and gratitude to my colleague and coworker, Neptali Ramirez, who is working behind the scenes on a lot of the technological and logistics efforts. So just a lot of appreciation and gratitude for you, Neptali. So with that, I'm gonna pass it over to our dear colleague, Wendy Todd, who is the moderator for today's program, who will lead us through introductions and framing for today's discussion. Over to you, Wendy.
Thank you. Hi, everyone. It's so great to see you. I'm so glad you're spending this beautiful afternoon with us on this very important topic. We've been planning this meeting for a bit, and I'm really thrilled that there's so many beautiful faces here with me to talk about caregiving. So I'm a consultant. I was hired by May and Stanley Charitable Trust and MetaFund to help facilitate a design team to shape this group we're calling Aging Intersections. And this design team includes MetaFund, May and Stanley Charitable Trust, the San Francisco County Aging and Adult Services, Shireen, Unlock, Justice and Aging, the Walter and Elise Haas Fund, Hirsch and Associates, and hopefully I'm remembering everyone. So many of the design team folks are here that helped shape this, this particular meeting. So today we are going to talk about caregiving and think about it from multiple perspectives. It is a very complex topic that that our speakers know very deeply and intimately. And we know that folks on this call or in this meeting are coming at this topic from really different experiences and perspectives. So what our point is today is to give you a taste, a flavor of the deep information that's out there around caregiving, paid, not paid, family caregiving, what happens in the public sphere, in the private sphere, what do we mean by care economy, and how is all of this sort of topic being impacted by COVID, particularly among people of color and low income folks and older adults in particular. So we have a great agenda planned for you to really deepen your knowledge and also for you to share your knowledge. So this meeting is not just only sort of folks talking at you, but we know that lots of people on this call have information to share with one another. So this meeting is designed for the speakers to do almost an impossible job of sharing a very little amount of what they know. And then us opening it up for you all to ask questions back to the speakers. We'll carve out time to do that in sort of this virtual meeting space, but also on the chat as well. So it's really meant to be interactive. I encourage you to show your face because as a speaker, it's easier to see that you're actually talking to people who are living and breathing than to not do that. So with all that being said, I would encourage you, we've talked a lot about this on the design team of thinking about older adults in general as assets to our community, and to think about caregivers today in particular as just this incredible resource that we are as caregivers and that we know as caregivers bring to our universe. So I encourage you, if you feel so moved, to put into the chat what value a caregiver has brought to your life or to someone you know, to sort of set the context for the great, tremendous value that caregivers bring to our lives. So I will turn it over to Renee Espinoza at MetaFund to give us a little context about what is aging intersections. Renee, go ahead. Oop, you're on mute, Renee.
Welcome, everyone. And thank you, Wendy, Daniel, and the entire design team for your work on today's webinar. I'm Renee Espinoza, Director of Program Strategy at MetaFund. I'm excited about today's meeting as I just joined MetaFund in September, and this webinar has been in the works for some time. I'm really looking forward to diving into this important and timely topic that brings us all here today. I must say, when I joined the philanthropic sector, I was surprised to learn that just 1% of philanthropic funding is directed to organizations serving older people. I learned that until very recently, philanthropy hadn't really tuned into aging or older adult issues. There may be a stigma or a true misunderstanding of the challenges and needs of the aging community. And yet the reality is that every foundation's strategy and each program area somehow touches upon older adults. Whether a foundation is focused on housing or health or job creation or the arts, their funding impacts older adults and their communities. Aging issues are intersectional and do not exist in silos. The Aging Intersections Funder Network was formed with the recognition that every funder really has a vested interest. We believe philanthropy can and ought to do more to erase the disadvantages that older adults, especially elders of color, face in our society. And of course, this past year has made this all the more urgent and apparent. As a collaborative, we are focused on supporting direct service provisions and transforming the systems that support our diverse communities as we age. In the past year, we have co-hosted several learning webinars with NCG with the intention of building a community of folks who represent public and private foundations, public agencies, and nonprofits. And with this in mind, I'd like to extend an invitation to you, if you haven't already, to join our efforts. Please reach out to me via email or through the chat function if you'd like more information about aging intersections. So as you know, we have an exciting lineup of speakers in our limited time together today. And given that we'll be learning about a tremendously complex issue, let's get started. Thank you again. I hope you enjoyed today's session, and back to you, Wendy.
Thanks, Renee. And I forgot to mention the fun fact is that Renee, before joining MetaFund, was 7 years the executive director of San Francisco court-appointed court-appointed special advocates for young people involved in the juvenile justice system. So I love when people make that transition from working in the sector and then moving into philanthropy. So thanks, Renee. I'm glad that you're a part of our group now. So we're going to do a quick polling question to get the brain cells moving on some trivia, and then I'll turn it over to our speakers. So Nathalie or Daniel, you want to bring up the polling question? It's an easy one. We're starting out easy here. Oh, okay, we'll just do the first one. To start out, what's the trend of unpaid caregiving in America? What is the trend? You can all imagine.
You might not be able to submit since there's 2 on there. I couldn't.
Oh, okay. I don't know. It's
Yeah, you have to complete both in order to submit it.
Okay, so yeah, go ahead and do both then. And I'll let you know. Okay, thank you. So let's end the poll. And yes, increasing. So the number of people, I find this fascinating, the number of people who are caregivers for either children, adult, or someone with special needs is 53 million people in the United States. That has that number's increased since 2015 by 3 percentage points. And the other thing that's increasing around caregiving is folks who are unpaid caregivers are showing an increase in reporting that their own health is fair to poor. So not surprising, and we'll hear more about the data from Dr. Heather Young. And then the percentage of people who provide direct care who rely on public assistance. So in other words, they're not making enough money in their job to live without, right, using public assistance. And so this was oh, I tricked myself. So yes, all the answers were correct. It's 49%. So close to 50% of caregivers in homes and nursing facilities rely on public assistance. So this issue that we're going to talk about, it crosses so many topics around racism, economic security, health. So it goes on and on. So we have dynamic speakers today to kind of share all the complexity. I'm going to close these polls here. And to start us off, we'll hear from Sade at Caring Across Generations. And I love that Sade is a proud member of the sandwich generation. And Sade will start out with sharing her care story. Then we'll go to Dr. Heather Young, who's at UC Davis, who spent 30 years doing research on caregiving and most recently has learned about caregiving by being an active caregiver herself. So often this topic is personal and professional. We'll hear from Annie Chung, who's the executive director and president at Self-Help for the Elderly, who is very proud to have received the vaccine. And 200 of her staff at Self-Help for the Elderly have also been vaccinated. And then we'll hear from Josie at Caring Across Generations as well. And the only fun fact I have on you, Josie, is that Sade shared is that you're a plant woman. You love plants. So we'll go We'll go with that. All their bios are on the NCG website, and we'll put that in the chat so you can learn the depth of knowledge that these folks are bringing to us. So with that, I'll turn it over to you, Sade.
Hi. I'm sure Josie will give a little bit more context and amplification around who she is. But thank you for having me. I'm really happy to share a little bit about my care story. So my mother, Celia, is a sprightly Puerto Rican woman from the Bronx, and she taught me how to care. She cared for my mother, who was a care worker, who became blind right before my mother was born. And then when I was born, my mother shifted her career. So she worked as a stay-at-home mom and reminded me of that my entire childhood. But mostly she reminded me that we care together and we just make it work. So when my partner and I welcomed a child into our family in May of 2018, we knew that we were going to care together and we would figure out what exactly that meant for us. And we would once again make it work. So we were able to have a nanny come in part-time. And as I worked from home, my mom jumped into action with the other half of like the work week responsibilities of caring for her new granddaughter. And funds were tight and it was a delicate balance, but together we were making it work until it didn't. In October of 2018, when my daughter was around 6 months old, my mother had a major heart attack. So overnight, I became a family caregiver in a different way, sandwiched between those two generations of needs. So I became the coordinator of doctor's visits. I went through medication pickups and changing diapers while also answering the phones. I was an accountant, a personal shopper, a health coordinator, an advocate. I was also a mom in my late 20s, Black, Latina, a woman with a disability of my own, trying to navigate the care system. And all the time, my mother's mantra of like, we care and we make it work kind of rang in the back of my head. I faced impossible choices daily. It was, do I choose to go to work over taking my mother to a doctor's visit? Do I sit on the phone with Medicare for 2 hours trying to get off of a wait list to get a care worker into the house, which seemed impossible unto itself? And so many things felt impossible. The reality of the situation was that it wasn't actually working and no amount of finagling was going to make the system work. So my previous job was asking me to work at full capacity, and because that's what's expected, vacation days only go but so far. And my mother needs support with getting a wheelchair, but Medicare coverage only went so far. And the care bills for my nanny were piling up. Money only went but so far. And I was one person and I continue to be one person. So I could only go but so far. And it wasn't sustainable. It's not sustainable. But together we tried. We put together a patchwork system because between all of us, what we considered our care squad, right? Our doctors, our care workers, our family, our friends, we were able to figure out how to plug in holes and set alarms and figure out who would take what shift. And it felt like barely enough and it didn't seem fair. And that's because it wasn't. In February of 2020, right before the pandemic, I came to work for Caring Across Generations. So for those of you who don't know, Caring Across Generations is a campaign working to change how care is valued in this nation through a few ways. There are policy advocacy efforts, state mobilizations, activist networks, culture change activations. But all in all, we're founded in the idea that there needs to be a shift on all levels to realize that the work that I do, the care work, is valuable and it's collective. So I think in that moment when I came on was when it clicked for me that my story isn't the only one. There are 65 million family caregivers, very similar to myself in the US. And by the next generation, my daughter's generation, there are going to be double the population of 65 and older that exist. So the current care system as it stands is stressed beyond capacity, and what's currently happening just isn't working. So people are talking about care in a different way, partially due to the light that the pandemic has shined on our care infrastructure. People are having conversations outside and inside of their families about the realities of aging, the realities of caregiving, how it actually is work, and how making it work, like making this idea of just doing what you can, isn't actually working. And it's something that shouldn't fall on the individual. So one way is to shift that is to talk to more caregivers like myself, but also to come together through a collective strategy to figure out how to really build a sustainable and collective system that works.
Thank you, Sade. Yeah, thanks for sharing that story. And we'll keep your mom and your daughter in our thoughts as it's a daily experience. And we're going to talk about what some opportunities are in this meeting around the 1:45 mark. So we'll lay some more context. And I really appreciate you sharing your story. And I'm guessing that there's lots of people on this call also have a care story or two to share. So feel free, if you feel so inclined, to do a thumbs up. To sort of share, like, yeah, you get it. You get what Sade has experienced or is experiencing, at least a slice of it, perhaps. So I'll turn it over to Dr. Heather Young to tell us more about the context for caregiving.
Thank you, Wendy. And thank you so much, Sade, for sharing your story. It's my heart goes to you. What an amazing journey you've been on, and so unexpected. And also to think about the fact that you can actually, on top of all your demands, change your experience into strategy. You have my deep admiration, and I'm really thank you for being here to share that with us. I want to talk a little bit about the caring in the United States, both families as well as the direct care workforce. And those are the two major contributors of care for our families and for our loved ones. I'll talk a little bit about family caregivers first. Families are, and the data that I'm citing is mostly from the 2020 Caregiving in the U.S. report that came out from the National Alliance for Caregiving and AARP. It's a large national study. And what they found was that 1 in 5 households in this country are providing care. And as Wendy said earlier, 53 million people, and it's up by 20% in the past 5 years alone. So it's definitely on the increase. And what we found in the study was that it's across the lifespan. People are caring, whether you're children caring for older people or aged people yourselves caring for each other. It's across all racial, ethnic groups, sexual orientations, income levels. It's a really universal experience. And 90% of the care that families and friends provide is for a relative, and about 40% live in the same house. Importantly, not just are there more caregivers, but there's a trend for increasing intensity of care. Much more complex needs are being reported on the part of the people receiving care. And the average caregiver is giving 24 hours a week and cares on an average for 4.5 years. So this is a long-standing commitment. And about a quarter of caregivers are actually caring for more than one person. And often different members of the family and the caregiving group contribute different kinds of resources to the story. The economic estimates, and I think they're underestimated because they use minimum wages as a reference figure, but there's 34 billion hours of caregiving in a year given by family caregivers. And that translates into about $470 billion. This is more than the total out-of-pocket spending on healthcare in the U.S. It's also more than all the money that's spent on paid caregiving. So it's really an extensive amount of contribution by families. 60% of caregivers, as Sade talked about, are employed, and they're juggling their responsibilities. And only 30% have any help to augment their ability, any paid help. And about half of employed caregivers who are engaged in intensive caregiving actually have negative impacts on their ability to remain fully employed. Some have to quit their jobs, reduce hours, or take on a less demanding position, or not take an opportunity for promotion. And these reductions in full employment and salary have long-term financial consequences. They reduce income in the current time, but it also affects retirement savings, accrual for Social Security and benefits, and it limits career opportunities. So it really threatens overall financial well-being. And the estimated loss of income and benefits for family caregivers over 50 is over $300,000. And 80% of family caregivers incur out-of-pocket costs. And this is where you get some intersectionality, because it's even higher percentage of family income. For Latinx family caregivers, it's around $9,000 per year, which is about 44% of the median income. And it's 34% of median income for African American caregivers. Millennials, I worry about millennials a lot, and people who are younger caregivers. More than 1/3 earn less than $30,000 a year, and the long-term financial implications for them, starting now going into the future, really are a serious concern. So economic strains are important. There are also costs that go beyond the economics. There's personal costs, and every caregiver has different motivations and rewards for caring, but there are many stresses and sacrifices, enduring effects on physical and mental health, as well as burnout. And many caregivers report feeling alone, very isolated. In fact, it's even more common among Black and Latinx caregivers to say that they feel socially isolated. And there's a really well-established linking between the stress of caregiving and health. And so caregivers sacrifice their own health for the care that they're providing. I'm going to turn to paid workers. There are 4.6 million direct care workers in this country, and these include personal care aides, home health aides, nursing assistants in nursing homes or assisted living settings, and they provide help to older adults and people with disabilities. In California, there's 600,000 home care workers. Some of those are paid family members. But we expect a need for an additional 200,000 by 2024 in California. So a tremendous need, growth of need, and there's a trend for greater growth in home care. This is the fastest growing occupation in the U.S. right now, and we're expecting in this decade to need 1 million more people to be delivering home care. And this is just the paid workforce. This doesn't include the gray economy, and there are many people who are hiring people to help them without having it be recognized in formal ways. So they're not on the payroll. So this is a huge economy. The paid workforce for direct care is predominantly female, almost 90%, predominantly Black or brown, 59%. It's just over a quarter immigrants, and just over half have less than high school education. They're paid comparably to fast food, and in their daily work, they deal with complexity, intensity, as well as physical and emotional demands. The average wage is $12.80 per hour, and this has increased a whopping 19 cents over the last decade. So the average median wage is just over $20,000, so that more than half of the workforce is below the 200% level of federal poverty. And as was said earlier, about half rely on public assistance. So this is work that is really demanding. It's also characterized by heavy workloads, scheduling changes, inadequate supervision, and a lot of turnover. And it's a highly stigmatized workforce, undervalued and unrecognized in society. And the pandemic really brought this into sharp focus, as direct care workers were among the very last to get PPE, training, and paid leave when they or their family members were ill. And it was even more exacerbated for those who come from communities that were really hit harder by the pandemic. I think that the economic status of caregivers is a study in intersectionality across race, ethnicity, age, immigration status, language, sexual orientation, and gender. And there's a legacy of caregiving as being the responsibility of unpaid or very low-paid women and persons of color. And within this workforce, brown and Black workers make less than white workers and are more likely to live in poverty, work in under-resourced settings, and experience strain and burnout. There was a recent study of national study of nursing assistants that revealed that while these caregivers really appreciate learning new skills and the challenge of the work, they're very dissatisfied with the turnover and with their salaries. And the satisfaction is related to both race, ethnicity, and citizenship. The greatest satisfaction is among immigrants, who have the very highest satisfaction, Black, Latina, and white immigrant women, followed by Latinx and Asian nursing assistants. And the males in this field don't have an advantage that's typical for males that are in other fields where they end up having a more of an advantage in an organizational setting. And really, the African American nursing assistants are the least satisfied, and it's very consistent with both the overt and covert racism that occurs in nursing homes, both in terms of the organizational structures and the ways the clients actually treat their care workers. And economic status has a major impact. Caregivers who are in low-paying jobs without benefits are the hardest hit. Many lower-paying jobs don't offer benefits, including paid family leave, and offer little time off or flexibility in schedule. So caregivers really risk penalties if they have to attend to their caregiving responsibilities at home. Employed caregivers are also less likely to take promotions and increase their income. So this is a group that's at economic risk, and in many ways an exploited and very invisible workforce in our country.
Thanks, Heather. Thanks, Dr. Young. Yeah, it's a bleak landscape, and I appreciate you bringing the information and connecting the dots for us. And on the flip side, Annie Chung at Self-Help for the Elderly is a light in the bleak landscape, I would say. So Annie, tell us about your work, what you're learning, what you're doing around paid caregivers, setting the context.
Thank you, Wendy, and thank you, Dr. Young. On the community level, I think that we see exactly what your data shows. And for Self-Help for the Elderly, we're really a very grassroots community-based organization. And so the caregiving was started because we kept hearing from our seniors that they needed someone that speak their language to take care of them. So even back in those days when they were getting IHSS workers, but if just anybody that only speaks English go take care of them, there won't be really any communication at all. So at the same time, because of the immigration reform, a lot of the women are coming back to San Francisco to join their loved ones because they've been separated from the men and the husbands. And there's an influx of really older workers, older immigrants, but very monolingual and almost lack of skills coming in. And we know that for them to be eligible for Social Security retirement benefits and Medicare, they have to have a 40-quarter, minimum of 40-quarter or 10 years of gainful employment. And so we started this home health aid training program way back probably in the early 80s. So that the older workers get at least 10, 15, sometimes even 20 years and fulfilling that requirement. And then when they turn 65 or older, they will get Social Security and Medicare, which is very, very essential for them. So that's really how a community based on self-determination, started the caregiving. We provided steady training of licensed home health aides for the past 40 plus years. And in the beginning, we were training almost 100 home health aides each year. But later in the last 8 years, we're only able to provide licensed home health aid training to maybe 30 trainees because of the funding diminished quite a bit for the home health aid. So that's how our paid caregivers become like, it's so important to provide this pipeline, right? As Dr. Young already said, in about 5 years, we're gonna need 500,000 home care workers. And if we don't have this pipeline, then the percentage that Wendy gave us, 63 million family caregivers, would probably have to increase tremendously because there's nobody really in the workforce. And just like Dr. Young said, caregivers, even paid caregivers, tend to be very low paid and undervalued and under-recognized. So a lot of the younger, older adults or even younger adults don't want to come into this field. It's really hard work. You take care of seniors that sometimes have a lot of personal care, sometimes have mental issues. They might be incontinent, immobile, and quite a lot of demands. So you have to have a lot of patience and love and commitment, to be in this field. So I think that the values, though, that they bring, the paid caregivers, they, particularly if they are bilingual and bicultural, they are just so valuable, because for the frail seniors that are dependent, on the caregivers for a better quality of life and be able to actually stay in the community versus going into a nursing home or a long-term care facility. These are paid caregivers who are trained professionally, bring maturity, sensitivity, reliability, and their rich life experience, particularly with the older caregivers, which has made up a large part of this care population, just add value, to the caregiving and to the people who receive their care. I think that during COVID, the lack of clarity in the beginning, during March and April, and even way into May, make a lot of these gaps in the caregiving, whether they're IHSS workers or paid caregivers or even family caregivers. Nobody knew who should continue to go to work. Some seniors are afraid to let anybody in. And also some of the older workers are also afraid to go to work. So until HSA and IHSS clarify, that there's an emergency unit to take care of some of their needs, everybody was calling everybody for help. So it shows you that the system still have a lot of gaps. And to prepare for another pandemic like this one, we really have to think, where are the gaps and how do we fill it, both on the public, private, and the nonprofit sector. So I think I'll stop there and see if other people have other questions later.
Thank you, Annie. Yeah, I wanted to be sure that we had a chance to answer questions. So feel free to put questions in the chat if you'd like. We have Josie to also share her perspective on setting the current context. And then we'll open it up for a Q&A, but then we're going to talk about opportunities. This isn't going to be a completely sad and depressing reality check, which it is, but we'll also talk about some opportunities. So Josie, I'll turn it over to you to round out the context before we go there.
Yes, thanks, Wendy. Thanks for everyone on the call for joining us and for having me. I think a few things that I want to say to maybe attempt to tie a bow to the brilliant things that have already been spoken. I think it's important to think about the issues of care and caregiving in a few different contexts. One, if we all sort of imagine ourselves into this glorious old age and living, living well beyond the next year, the next 5 years, should the universe bless us in such a way. And the reality is, the ability the ability is very fragile. So whether it is because of old age or because of ability, because of an accident, whatever the reason may be, the likelihood that we will all need care at some point in our lives is very real. And there are, if we don't need care, it is more than likely that if you haven't already provided care, you will be providing care. And there's many different situations, reasons that all of those things can be. And it's important to remember that we can't just have a fantasized version of what caregiving, whether paid or unpaid, looks like. There are 63-year-old working caregivers that are caring for an adult disabled child while caring for their spouse, right? So the faces of caregiving often overlap with the needs with needing care. So we have a lot of caregivers that are also at the intersection of needing care themselves. All of this is amplified by all of the systemic challenges that many of you all on this call already know about and are already trying to address in your work. So we have to think about the systemic causes of these constant reoccurrences of the care and caregiving spectrum. So not only is it nearly impossible to afford the care that many of us will need on a long-term basis. So the average person, should we be so lucky will need care for at least 3 years. Will need long-term care for at least 3 years. Many of us are working much later in life and still depleting savings because wages aren't keeping up with the cost of living. So this idea that we once had that there's going to be this nest egg that's like comfortably somewhere for the point that we retire is just not the case anymore. And then in addition to that, because many people don't have that nest egg, because people think Medicaid and Medicare is going to be there for them in a different kind of way, or because they think life insurance and health insurance is going to cover their needs, the reliance on family caregivers is just a growing demand. And the relationship between paid care workers and unpaid caregivers is inextricable. So we find people who need care, who can't afford care, relying on informal care supports, often from family and friend care. Then at the point that that person can no longer give care for whatever reason, many people have to go back to work. Many people become overwhelmed. The undeniable need to then figure out some patchwork way to afford a paid caregiver is almost inevitable depending on the length of time someone needs care. All of this is undergirded by systems that were never meant to support the population's impact, the growing population's impact on our care systems. In addition to that, you've already heard about how care and caregiving is fundamentally grounded in this country's historical roots of slavery and racism, which means that care is not valued, care workers are not paid a sustainable enough wage to even save money or care for their own families. And when you overlap this with the race and gender realities of both needing care and providing care, it means that primarily women and women of color who are already underpaid, who are already often systemically shut out of opportunities, are then going in debt to care for their loved ones who went in debt for the opportunities that they needed to provide for their own children. And we're setting up generations to constantly age into poverty. And there is this fantasized notion that when the care bill comes our way, we're going to figure out how to pay for it, or that it will be at a rate that's affordable. But I talked to lots of parents, for example, who didn't expect that bill after they birthed the child. And so if you imagine that level of surprise to then come at the end of, at a particular age when people aren't working anymore, or at the point that care has disrupted someone's ability to work and engage in the workforce, that bill is a surprise for everyone. And the reality is, no matter how much money one thinks they're making, that's going to be depleted very quickly because of care and caregiving. All of that is to say that we have to not only think about this from an individual perspective and from a communal perspective, but we have the responsibility of also thinking about this from a systemic point of view. We have to ask ourselves, what are the workforce supports that people need to be able to both give care, receive care, and stay engaged in the workforce in order to shore up their retirement realities, right? And Social Security credits and some of those things. And then we also have to think about, what does housing supports look like? What does affordable care look like? If a majority of our population is going to rely on public benefits to access care, what are the supports then that family caregivers and the care workforce also need? And before I pause, I wanted to just say that when we think about the underlying factors of all of the most impacted people across all socioeconomic and social justice issues, we're talking about the same folks. So whether you're thinking about how far wages go, who's shut out of housing, who's shut out of education and opportunities, who's shut out of care and caregiving, we're talking about the same generally impacted populations. And if we really want to disrupt generational cycles of poverty, we have to center care, and we have to create an interconnected care economy that works for all and centers the most marginalized. That's the only way we're going to get it right, is to ask ourselves, what's working for Black, immigrant, disabled women of color, right? And if we're not centering that question and how we are asking ourselves about solutions, programs, and impact, then we're going to find ourselves having the same conversation a year from now, 5 years from now, 10 years from now. So that's that's one of my commissions for this group, is to think about who we're centering and how they're involved. And we'll talk more about some of those solutions and opportunities, how to do that in real practice, and what that means about the outcomes that we can look forward to in what we say by 2030 is our deadline at Caring Across, to fix all of this.
Oof. Wow, Josie, well said. Thank you all of our speakers for really laying this context. I mean, I know it's so complicated, but you all distilled it down and really drove the point home. So I'm going to keep us moving. It's 1:45, and I promised that we would move to some solutions and opportunities, some examples of where we're seeing some movement, with the hope that all of you on the phone will learn something, take a nugget, follow up on it, act on it. And if you have information to share, we're going to open it up for a large group discussion to hear maybe some opportunities you're hearing in your universe. So we'll start back with Sade to share your perspective on future opportunities.
I have to follow up. Okay, absolutely. Yes. I mean, it's so shifting gears a little bit. There are some systems change points that I want to touch on, but I also want to touch a little bit around some of these narratives that we're hearing and shaping, making sure that we're putting family caregivers, especially those most impacted by the fragments in the system, front and center. So, I mean, at large, in particular, Caring Across is always in need of resources that help amplify some of these care narratives. And when we break into common public language, I think that this is part of where we're starting to see the disconnect, is that there is not a shared language, a shared culture around the collective responsibility of care. So we know that to create sustainable change, we have to make this work on all levels, and moving both the minds, but also the hearts of stakeholders. So pause. So when I think about aging related culture change efforts that shift public understanding, for example, in California, Caring Across is one of our biggest projects, actually, is a scaffolding project in California that focuses on convening care groups, moving comms and narrative culture change efforts. But then there's also a comprehensive multi-city study assessing the landscape of the current care system in California, the benefits, their reach, their economic impact on working families in the cities of San Francisco, LA, and then Sacramento. Those are our three main cities at the moment. And the most powerful thing that we've seen with other pilots that are similar to bringing some sort of comprehensive benefit, such as the Universal Basic Income, the UBI study, is that storytelling and narrative work, even the way that successful research studies like UBI have been very focused on beautiful and compelling explainer videos, amplified profiles, animated stories, as we look to strengthen the care infrastructure within California and across the nation. We know that we need qualitative evidence as well as those quantifiable stats. So it's finding the balance behind that and making the investment in those stories. So within our culture change strategy, there is also the understanding that culture change works both as a vehicle for advocacy and policy shift and systemic change, but also within that support of the public's larger understanding of care, and that we are all deserving of more, I think. So while simultaneously running narrative strategies on the advocacy level, we're also holding parallel work that include ad campaigns and digital engagement strategies and multimedia strategies. We currently just ran an ad campaign in DC that had, those big bus stands. They had those big posters that prompts passerbyers to to think about in like very large font, like, have you talked with your loved ones about how you'd like to age? So things that really captivate and start a public dialogue around those core components that we know are relevant and applicable and needed to start the conversation around building a care infrastructure. So yeah, stats and numbers, they move some. And what we found though is that stories articulated through multiple mediums and platforms move many. So that's
Yeah, and I'll just quickly add to that, that one of the things that we have to counter, particularly in culture change work, is the idea that that the overwhelming demands of care that can be really disruptive to life are both an individual and family failure. You know, there's that sense that like, we did something wrong, I did something wrong, I should have more in the bank, why didn't my parents do XYZ, why am I in this situation? And countering that narrative and that belief gets people then to understand that there's actually a systemic failure that needs to be addressed through policy and systemic change. And it is the storytelling work and the public education work that allows us to counter that narrative, right? Otherwise, care work tends to be the work that happens in people's homes that nobody sees. It's the invisible work. It's the work nobody talks about, particularly because part of our culture is such an individualized, pull yourself up by your bootstrap, make everything work, juggle all the things. And if you drop one of the 80 balls that you're juggling, then you have failed, versus actually we should have an economy that allows for equitable access to resources so that things can be done in a way that doesn't, you know, that doesn't mean that you leave work or you turn down job opportunities or that you put off having a family because of the cost of caring for an adult loved one. So the storytelling work is really important to build a base of support and demand for the systemic change that we want.
Thanks, Josie. Yeah, and thank you for the questions that you're posting. We'll get to them during the Q&A if we don't get to them during the speaker presentations. So Dr. Heather Young, go ahead and continue on with other opportunities in addition to storytelling that can solve this, crack this nut.
I'm so happy you invited me back because I was a doom and gloom person in the first part. So I'm so glad to bring a little bit of light and hope to the conversation as well. I think there's some national policy issues, and Biden and his team have an agenda around caregiving. Some of it is around minimum wage and increasing minimum wage and assuring benefits for people. I mean, fundamentally, we have to correct some of those economic issues. But there are also policies like paid family leave and extending it to smaller businesses, really making sure that's a benefit available for people. I think in three buckets when I think about how to approach and deal with this. One is new models of care delivery and for training and career ladders. It's not just enough to add more people. Sade really outlined how many people are coming in the future that we need to be worrying about when we think of her daughter. And so just adding numbers isn't the answer. We've got to redesign how we do care. So I think there's funding opportunities to look at how to do demonstration projects, waivers, different ways of imagining different ways of delivering care. And when I was serving on the California Commission for the Healthcare Workforce, we looked at the idea of a universal home care worker and really creating it as a career ladder opportunity. And I think that has some, it addresses some of the underlying economic issues as well. The second area I think about is building capacity that's culturally and linguistically appropriate. We need to think of pipeline recruitment, training, and support. In California, with the growing diversity that we have, it's imperative that we grow a workforce that assures that older adults and persons with disabilities have access to people who can give them care in a holistic way, considering their own language with respect for their culture, sexual orientation, their identity. So this is something that we really have to build capacity in. And then the third area that I think is quite intriguing is the overlooked workers. People who are older adults who could contribute in many ways, maybe not in the physically demanding aspects, but could be resources in our communities and to working caregivers, providing emotional support, providing navigation with instrumental activities of daily living. These could be newly retired people who retire pretty young with a lot of vigor and have a lot more to give. And they could be partnered with people who are needing support. And it could be a way to provide additional finance and support to retired people who have not accrued those kinds of benefits in their life and want a second career. So I'd really like to see some partnerships that could be creative at the community level and among agencies like AARP and the AAAs and different groups where we could think about these overlooked workers. And the gig economy is a good example. You know, companies are starting to do things for older adults and are bringing people in a much more as-needed kind of a way. And I think there's some real opportunity in looking at new ways of delivering care.
Yes, thank you. Thanks for those 3 buckets. It's helpful to think to segment the solutions into 3 priority areas. Annie, what would you like to add to this idea of, or this topic of future opportunities?
I think there are lots of ways to support a community-based training program, particularly to bring cultural competence, more bilingual, bicultural caregivers to add them into the workforce. So publicly, self-help for the elderly has been relying for many years on the community college system to provide the instruction, the instructor, which is an RN, to teach our home health aid classes. And it's been a very successful partnership. But until about 10 years ago, somehow that training could not continue. So we have to look for a private trainer that is very, very costly, almost $5,000 to $6,000 to train a person. So we look to our city and county workforce and economic development, OEWD department, to fund a home health aid training program for us. So we kept looking here and looking there, and thanks to really the Dobie Fund, the Dobie Family Fund, Meta Fund, and the Google Foundation, they reached out to us to see, you know, in the area of supporting our aging population, what can be done. And we thought that to fill the gap and to provide us a continuous way of a training program, a bilingual, bicultural home health aid training program, would really help to fill both on the recipient side as well on the caregiver side. As I said, employment and self-sufficiency is one of the core mission of self-help. So we feel that in San Francisco, our home health aides get between $17.05 is a living wage here. And so we, for our home health aides that are now working for us, they get between $17 to $21 in wage. It's still under what, 40,000 a year. It's still very low wage. But joy comes to us is when an immigrant, older worker fulfill their 10 years of employment FICA taxes history. And then, you know, when they get Social Security and Medicare, and along with other family members, they now, you know, could support their family to buy a small home outside of, say, Chinatown. They would come back to us and said, because of the work employment history, they feel, you know, very proud that they could now retire and their family could afford a home. So all those are really important for, I think, today's group to think about how do we make the appropriate investment in the community, knowing that caregiving is such a big part, you know, of taking care of our loved ones. How do we support the caregivers, the paid, actually, as well as the family caregivers? So, you know, we're looking for ways to cut down the cost of the training so we could provide more training, you know, to more people. And also, if we provide some renewal classes, because a licensed home health aide need 24 hours of continued ed in 2 years. But if the home health aides that are working are so low wage, sometimes they can't afford, you know, to go pay another several $100s for a renewal license, then they would lose the license. And it's not going to work for us in the long run. It's not sustainable. So we hope that we will, you know, be able to gradually or finally find enough support to have some public, private, nonprofit partnership, you know, that will allow us and enable us to train, let's say, 30 to 50 licensed home health aides every year, and then also provide renewal classes for those who are already licensed. And in addition, we could provide, if we have such a school set in the community, then we could also provide maybe 12 to 15 hours of training to family caregivers who's always looking to us for tips in taking care of Alzheimer patients or seniors with Parkinson or seniors that have some mental issues. How do they take care of them and provide the best care? So all that is really important. But if there's no source of support, then we have to give up, on something. And I hope that I never have to give up continual training of licensed home health aides for our community, because I know that our elderly depend on them, depend on having bilingual, bicultural caregivers to take care of them as they get older and older, and they don't want to move into a nursing home. So
Thanks, Annie. Yeah, and I love the ripple effect of that, the training program, the impact ripples into the family, to the community, and being able to leverage what the training is for family caregivers in addition to paid. So there's so many wins in what you're doing. Thanks for sharing that, Annie.
Thank you.
Josie, I know that there's some chatter happening on chat, which we'll get to. But yeah, really wanting to hear your perspective on opportunities that funders should pay attention to.
Yeah, so there's a few opportunities that I would elevate, particularly for funders and philanthropists. I think one, we have long been trying to socialize the idea that caregiving systems are an important infrastructure of this country that needs to be built and rebuilt and reimagined. I think, we're all sort of starting to hear the narrative start to happen about a recovery plan for the country, a recovery that's going to be focused on infrastructure. And this country often thinks about infrastructure as just brick and mortar, when really actually the infrastructure we need and the infrastructure of opportunity is really centered on the care infrastructure. And I think the more people that are talking in that way and talking about care as an infrastructure, as a cornerstone infrastructure of this country, the more we can really bogart into that conversation that tends to be really siloed into brick and mortar versus job ready infrastructure, right? Like it's infrastructure that if implemented in the next 2 weeks would boom jobs, would boom access to care, would allow people to like get back into the workforce in a way that feels fulfilling. So I guess one of like my very salient strategic asks is like for all of us to talk about care as infrastructure. And what that means for jobs, for systems, for care. So, and funders are influencers, are narrative influencers, are issues and topical influencers. People are listening for what you all are prioritizing, how you all are talking about things. So really talking about care as infrastructure is a key thing. The other thing is we have learned through various organizing experiments that there are a few really significant roadblocks for us to winning the economic system that we want that works for everyone. And so there's a lot of need to invest in case making work that's both like very research and wonky, right? Like how many people are we talking about would be impacted if we changed the requirements of Medicare, right? Like there's a particular population that is going to want to see those numbers, want to see the return on investment. And then there's public education case making that we need to do to cut these silos and to really prepare people for what our care infrastructure looks like. So in the case making world, I think about like one of our biggest challenges is getting economists and policymakers to understand that yes, the cost is going to be the cost, but there is return on investment and that we do save on the back end and that it's a front-loaded investment. We just haven't done enough of that research to say that if we invest here, we get this back in a way that helps us make the case that the investment is worth it, right? As opposed to like this siloing and picking and choosing of like $1 here and $1 there versus front-loading investment in the care infrastructure that we want and need. So that level of like really nuanced case making. The other two that I will just elevate as like case making, but maybe more public education. It came up in one of the chat questions too, actually. Nobody in this country understands this country's tax infrastructure. Nobody. I mean, nobody. So the minute you start saying raise the taxes on the wealthy, there's research that shows that everybody sees themselves either as wealthier than they are or like soon to be wealthy. So the minute you start talking about raising taxes on the wealthy, everybody thinks that's going to be me one day and I don't want that and I don't know what we're going to, everybody sort of like automatically sees it as a line item in their paycheck that they can't afford to pay any more on. So we need some more public education about what is the tax infrastructure of this country? What if you like pull on this tax lever, who does it really impact? What's the return on investment? What do we get for paying taxes? Most, I talk to people who don't know that their roads are in good conditions because of the tax infrastructure, right? And so there's like some education to do around there. And the other thing on the elder care side, the public is really, like, this country is really committed to seeing the care of children as a public good, right? And we're not there yet on the elder care side. Like something is disconnected there and we need to make a case for that. The interesting thing though is that when we look at paid family and medical leave, you gain more support when we talk about paid family and medical leave from the elder care side more than the child care side, right? So there's like something about how we need to do polling and real public education research to help people understand that actually the need to support caregiving infrastructure and the need to support an elder care infrastructure is also a public good. And then this will tie back to how people understand taxes, how people understand state budgets as a values document, federal spending as a values document. So there's something in there that we need to do. And then the last thing I will just say is like, and until you're like crash course in time caregiving, like we need to do the work of telling the story of caregiving and how we will all need care and how the care systems are actually set up in the way that people imagine they're set up, and do that constant public education, both in like very broad ways, but also identify trusted messengers for populations that we need to mobilize into our work and send those voices out, tell those stories. Because the minute people have an aha moment about care and aging and caregiving, they're asking us, okay, what do you want us to do? Who do you want us to call? But that aha moment needs to happen, and it happens through our public case making. That's both nuanced, because we need to talk to economists and academics and policymakers, and public, that we need to talk to our neighbors and help them understand that my neighbors like live on the 3rd floor and were fine, loved it until 3 weeks ago when she broke her leg, right? And now all of a sudden it's like, oh, this isn't great. And there are no supports, right, for me to get up and down the stairs. So those are the things that I would say is like also important opportunities for us, and opportunities to invest funders to really think about what's the public case making, and then how do we then sort of like experiment with what we learn.
Thanks, Josie. And a question came up from Kelly Kent at May and Stanley Charitable Trust. I'm wondering if you or Sade want to give some examples of your systems change work in California or elsewhere that you can lift up for us.
Yes, so there's a little like buzz here and there about policy opportunities. There's a few that I can point to and think about. In Hawaii a few years ago, actually, I think 2 years ago, we won a policy at the state level through advocacy work and through coalition building that offered an extra stipend of financial support to working family caregivers, which, like our public systems require you to not be working to access services, which doesn't make sense if we're trying to keep people in the workforce. And so this was the first of its kind where people that worked at least 30 hours a week could get an additional benefit for family caregiving work that they were doing. And most folks were really looking forward to using that to pay for a care worker jobs, right? So that they could pick up the extra 10 hours at work to maintain a full-time position and get benefits on their job, right? So that's like one very interesting model that we're then thinking, that we're thinking about piloting out and scaling in other places. The other thing that I will raise that's important and interconnected is just the movement around paid family and medical leave. One of the conversations that we've been really engaged in that movement is really around family definition, because how our systems and policies define family is going to really impact people on the elder care and long-term services and supports part, right? So if we have a very narrow definition of who family is and who can get paid leave, then that's going to like cut out a lot of people. We've seen this very exclusionary way show up in some of the federal policies responding to COVID, where they will say things like, it has to be your immediate blood family member that you live with who you can take leave for, right? And like, that just doesn't work for many of us. So this thinking around like, where do we experiment where existing policy exists to expand definitions of family, to expand definitions of care so that caregivers are supported, I think is really important. And then we're really seeing what Annie talked about like, where are training and support measures that we can offer family caregivers who are often thrown into a caregiving situation without any preparation. So we think about like, what does it look like upon discharge from a hospital to also require that hospital to touch base with a family caregiver and offer in-person training and supports as one way of offering supports to family caregivers. I will say that I think the most opportunity that we have is in thinking about city and state pilots that can then be scaled up to inform federal law, right? There's this like very interesting conversation that happens at the federal government where they want an example of where this is already happening. And then you get this city and state conversation that's like, we need federal support, right? So like, we need to figure out a place to sort of land that loop. And the last thing that I'll just note is in all of this, we're also fighting a scarcity narrative, right? We're in the economic environment that we're in, and states have the budgets they have, cities have the budgets they have. But at the end of the day, it sort of goes back to this return on investment case making that we need to do to really support this work. And sorry, the last thing I'll say, Wendy, is
No, that's
I think it's really important that we are intentional in building multi-stakeholder tables that are both like understanding this issue, advocating for this issue, and implanting it even in single silo issues. To that end, carrying across at the national level and in many of our states have brought together what we call care infrastructure tables, which are like people who may be working on singular issues like housing or paid leave, but actually at the core of it is being able to do the caregiving work that many of us will choose to do or be forced into doing, and to really think about how we set up a care economy that works for everyone. So we've set up a care infrastructure table at the national level as like an experiment of like, how do we identify moments where we are more powerful leaning in together before we get split up into single silo issues to demand the whole of what we want and need? And I think it will be interesting to learn from that to then pilot similar things at the state level so that childcare isn't pitted against elder care, so that state folks aren't saying, well, we'll do paid leave now and we'll do the rest 3 years from now, right? So how do we build powerful coalitions?
Thanks, Josie. And I know the question probably could be answered as well from Annie, Heather, and Sade. So I'm just curious, do you have anything else to add in terms of examples that you're seeing where systems change work? Maybe it's happening here in California that other funders might want to jump in on or learn more about or participate. Heather, you want to share your thoughts?
Sure. There was a demonstration project a number of years ago that looked at career ladders and improving opportunities for home care workers, and it's really demonstrated some dramatic results in satisfaction and in improvements. I know that Leading Age is working towards looking at the issue around career ladders and training and support. And I think that's part of what we need to do. It's not just addressing the economic problems, but also building a pathway for people who may start with family caregiving, may start with at the very bottom of the rung in this process, but recognize that they have this capacity to grow into professionals and if not professionals, grow in the roles where they are and become more well paid for what they're doing. So I think having those kinds of avenues where there's an opportunity for enrichment and which adds to satisfaction and also adds to self-worth and respect from other people, I think being able to be recognized for those kinds of achievements is really important, because we have to deal with it both from the emotional side of what people experience and their sense of worth and contribution, as well as the economic side of it for them.
Thanks. Sade, Annie, anything else to add around systems change that maybe funders want to, learn more about, contribute to? Annie?
Yes, at least in San Francisco, we Self-Help for the Elderly developed a Medicare licensed home health agency back in 1983. Again, based on the DRGs, we knew that our seniors are letting out of the hospital much earlier and sometimes much sicker. So we needed a home care agency with bilingual physical therapists, RNs, occupational therapists, and home health aides to take care of them. And running it for so many years, it's only about 3 years ago that we found out that as a licensed home health agency, we could actually add a component of training licensed home health aide under our home care umbrella. And that was like lightning, a bright light shine over us, because we were just hitting, like dead ends without any success, how to lower the cost. But so with Catherine and Janet and MetaFund and Renee's support, we're trying to get this license this year. And if we can, we're going to lower the $5,000-6,000 per trainee cost, down to at least 50%, because we still need to hire an RN to teach the class. But I think that's a policy. So I don't understand why for years and years they make licensed home health aide you have to go through a higher education institution to give you these classes. Our partner used to be American Red Cross, who loved to be our partner to provide these licensed classes. So I don't know, somehow when they switched that policy, we suffered, like we ended our training. So I hope that as Medicare thinks about the need for caregivers, they would expand, or at least, to make it more accessible for community-based agencies like ours to be able to conduct more training without having to be totally dependent on either public sector or a higher educational partner.
Thanks, Annie. Yeah. So the licensing, the certification, the requirements around Medicare and Medi-Cal. Interesting. Sade, anything else to add about caring across generations and examples you're seeing or opportunities you're seeing? And you're on mute.
Of course I am, because that's what Zoom's like these days. I would be remiss if I didn't mention and kind of echo what Josie's saying around coordinating work across the care continuum and continuing connecting long-term care, especially home care, with childcare and paid leave, and making sure that we're working in concert, echoing Josie's points there as well, to create a holistic care agenda. So I think that systems change ensures that working to make sure that care, especially home care, is at the forefront of the economic recovery agenda, and that we're bringing a strong equity lens that investing in care is investing in racial and gender equity and support for older adults and people with disabilities and children, and that that is what we need to be rooted in within this current landscape as we work towards recovery and a sustainable one. So Caring Across Generations is working on a long-term federal strategy that centers long-term care. And I'd love to follow up with folks if they're interested on that.
Great, thanks. I see in the chat a question around housing and making the point, I think Allison was bringing it up, how much, to what extent the housing crisis and the care economy are tied together. I wonder if Heather, if you have a perspective to offer.
Yes, I do have a perspective on that. It's a very big question. I just finished working with my colleague Jenny Chin Hansen on the master plan for aging for California, and that's a place to look at there's a whole section that we looked at on housing. But clearly there's a maldistribution of housing. There are a lot of older people who are living in pretty big houses with spare rooms without the ability to use all that space, and then there are workers who are sitting on buses for hours to get to where people need help. So some of it is a maldistribution of where people are, and I think there might be some innovative ways to think of intergenerational housing and ways to rethink how people live in our communities and have supports closer to them. I know during the pandemic that for people who lost a care receiver with the pandemic, the caregiver then was at real risk for not having housing and food insecurity, because they no longer had the IHSS payment available to them. And that came up as a real threat during the pandemic. And it's an issue all the time, but it really was highlighted during the pandemic. So they're inextricably linked. And when you look at people who are at such a low level in the economic strata, and then are on top of that, those kinds of issues around security for housing and for food are really very top and front and center.
Thanks, Heather. Yeah, any other panelists want to add anything else related to that connection between housing and caregiving?
Well, I'll just add that one of the things that I think often isn't talked about is the fact that many older adults in this country are on fixed incomes. So when you add the cost of care that's not covered, in addition to the cost of unaffordable housing, it just further complicates and confounds the situation. We saw an interesting attempt in Maine where a housing bonds and housing vouchers and affordable, accessible housing was part of their long-term care platform and part of a statewide bill for universal long-term services and supports. And it was an interesting experiment, but also like one way of sort of looping these interconnected socioeconomic issues together. And at the federal level, there's both the questions around how do we make housing affordable and accessible for all, and other incremental advocacy moments, such as how do you make sure that a spouse's income isn't factored into someone's need for care. That way you're not impoverishing two people and making homeless two people, right? So these are the sort of, when we think about the care economy and the care continuum, there are these very present needs and demands, and then there are all these other connected, interconnected issues that I think are equally as important. And the more we can experiment with tying issues together and sort of seeing where they go, the more we learn. We learned a lot, and we failed forward in Maine with this housing bond and long-term services and supports experiment, that I think some of those lessons are as valuable as winning, as winning a policy change.
Thank you, Josie. Yeah, it's so true. And you're speaking our language, because we are trying to look at the connections and the intersections. So to that end, I'd love to open this conversation up to hear from all of you opportunities that you're seeing in your worlds, in your purview, some opportunities that you want to share that funders on this call might be interested in exploring. And I know that Mona and Padmini, who weren't able to join us, Mona is from the Asset Funders Network, and Padmini from Walter and Elise Haas, right? I have that right. They both wanted to join us because there's a lot going on with the Asset Funders Network. So we'll be sure to send out information that's coming down the pipe from them. There's a Closing the Women's Wealth Gap, a national conference coming up. There's a AFN primer on the care economy that's coming out in a couple months. And so I don't know if any of you are engaged in Asset Funders Network that might want to do a little commercial brief of what's in the pipeline. Feel free to jump in. I encourage you also to put your name and your organization in your name, and let's have a dialogue. Let's open this up to discussion, to hearing what's coming up for you. Where are you seeing some opportunities? We talked a little bit about Master Plan on Aging. Maybe there's something there to explore a bit more. Maybe you have some further questions for our panelists.
Can I add one additional thinking, Wendy?
Of course, Josie.
We're often, maybe it's because we do the work that we do, but we're also often perplexed about the sort of perception that care and healthcare sort of stops at a certain age, and the delay that the funding world, we feel like, is decades behind getting into elder care advocacy work. But I would love just some, any sort of hypothesizing about the funding world's on-ramp into aging and care and caregiving issues.
Yeah, sure. I'm looking at Catherine and Janet in particular, who have been at this for a while and have asked the same question, I think. Anything you want to add, Catherine, to thinking about?
Well, I thank you, Josie, for the question. I think that I've thought a lot about this, and probably just want to say it just continues to be more questions than answers. I would say that in some of the research that I did when MetaFund came in, I would say that there was some very strange myths that were repeated and seemed to have gotten cemented in the notion that, as this, older adults were a large monolithic group and that they, quote, got a lot of money. And I think that was a pitting of older adults against the child world, and that, really comments around value of older adults having to do with, quote, return on investment, and that they were not a good return. And so I think that that has been one of the things that I had experienced anyway in the philanthropic sector, about why people had left. Some people had previously been in the older adult space and had left. And so that was a big question. So I don't have a huge amount more to offer other than to say, I think there is some renewed interest. And I think that it really has to do with more coordinated efforts of not pitting different groups against one another, and funders having a much broader perspective. And really, I think, again, I just want to stress, if funders are interested in equity, you have to, the opportunity of seeing older adults through this lens is incredibly fruitful, and there's just a huge amount of opportunity there. So I would really, encourage people to explore that lens.
Yeah, and so I'm curious, folks came to this call maybe with some understanding or interest around caregiving, maybe some experience doing some funding, maybe some questions around what's happening in the policy environment. So this is your opportunity to engage in the conversation. Feel free to raise your hand or jump right in, and we'll pretend we're in the room together. Kelly, and then Rachel Wick, who I can tell it has something to offer. Go ahead, Kelly.
First, just thank you to all of the panelists for just bringing your expertise and experience to this discussion. We really appreciate it. Josie, in the discussions, I appreciated you talking about Hawaii. I also wondered if I may have missed it. when I had to step out due to a package arriving at my house, if the Washington State example had come up around the long-term services and supports program that you all worked with state officials there around. And if not, could you provide just a little bit of background around that? I think it's just a really great example of another policy, statewide policy opportunity.
Sure. Thanks for that, Kelly. I don't even know how that escaped my mind. I didn't raise Washington, and will also put a pin in work happening in New York as an example. But in Washington, we did work over, we came in sort of the last 5 years, but it was definitely a 10 or 15-year arc of work in Washington that resulted in winning a statewide long-term services and supports benefit, publicly funded through individual contributions, as well as state government contributions, that all goes into a pool of funding that then people who need care can access at the point that they qualify for that. It was a campaign won by multiple organizations working in coalition together to both organize state, organize labor, organize. It was workforce voices, family caregiver voices, as well as the voices of people who need care on the disabilities justice side and on the aging side. And it had bipartisan support, pays through individual payroll taxes. So it's like people paying a level of tax, and had broad support across the state. And it was a powerful campaign. One of the things that we learned from there were a couple of things that we learned from there. Part of that campaign was really supported by an actuarial study. I know way more about actuarial studies than I ever thought I would in my life. But that data galvanized economists, academics, and policymakers, right, into a conversation about what was possible in their states. And the actuarial study also resulted in 3 recommendations for how to make a public benefit work. And even though it wasn't exactly the public benefit we wanted, it set a foundation for a statewide conversation about how to do this. And the other thing that I found really interesting, because oftentimes, as an organizer for one, but also as a social justice advocate, oftentimes policies that have significant exclusions are sometimes not where we want to go, right? So it was interesting in that campaign to hear people with disabilities saying, I won't be covered in this, but this is an important step for our state, right? Like, it's going to unlock and crack a door open that then we can organize and build on top of. The same for aging adults who are already out of the workforce, right? Who weren't going to pay into this program because they were no longer working, still say, I'm not going to benefit from it, but there are all of these people that will benefit from it. So it was definitely a masterful campaign of both research, stats and data, and storytelling, right? That I think was really important. The other thing is now we have a proof point at the state level that states can do this, right? And longitudinal data from this win is going to help us learn who's excluded and what's the impact. What's the impact on state budgets? What's the impact on people's long-term return on investment from paying out of payroll taxes, right? So some of these questions that are real challenges and barriers for us, we get to learn by having a proof point like Washington. And it's huge, right? We're already in conversations with coalition partners about how we build on top of that now that we have a foundation. And then the other thing that I'll just name that's been an interesting strategy and tactics, we've supported partners in New York. New York is kind of like California in that they're having statewide conversations about universal healthcare and a single payer, right? Single payer conversations. And there's a whole movement at the state level, similar to a few other states that are having single payer conversations. If you're paying attention to conversations around single payer and healthcare, long-term services and supports is left out, completely left out, right? And so we sort of like pinged that and raised that and had our partners in New York run a parallel campaign to include long-term care in their single payer bill. So they worked both with the movement partners that were pushing for single payer to socialize that within that conversation, and worked with advocates in their state house to include stuff in their single payer bill around long-term services and supports. Part of this goes to the, like, we sort of think about healthcare as ending at 45, right? Like, for whatever reason, there's this sort of like, at 45, I don't know what happens to people who need care. So there, so that's been an interesting strategy too, that's then sparked a conversation in the New York State House around long-term services and supports and home care. And actually, like, we have elected officials asking us, like, why was this such a big deal? And now we get to have conversations about how a continuum of care is really important, and supporting caregivers is also important.
I knew there would be bright spots. I knew that. Yeah, thank you.
Thank you.
Rachel, did you have something you wanted to ask or say or jump in with? Good to see you.
Just to communicate enthusiasm and support, I think, I work for Blue Shield of California Foundation, and we've drank the care Kool-Aid, that we can't have health across generations if we don't have care. And, I think this multi-generational story, which I've heard so clearly on the call, is powerful. And we're excited. I'm thinking about the master plan on aging and the master plan on early care and education. And both of those plans won't succeed without a stable quality workforce. And that can't happen without wages, benefits, and job quality for care workers. So I think if we can, there's been a lot of discussion about trying to find new partnerships and alliances. So I think building care worker alliances across sectors, linking to paid family leave. And I liked Catherine's comment about the formal and informal, because that's true in childcare and in elder care. And I think the more we can find these similarities and create paths together and maybe prompt some creativity, I think could be very cool. We're interested in state policy change and these major public investments that are needed in care, but also kind of investing in care workers as small business owners, in care cooperatives, kind of pairing a policy strategy with a kind of innovative bottom-up strategy for kind of thinking about wealth building, actually, more for care workers in that way. And care workers can't actualize paid leave if they don't have kind of a network of support for their business. And so, or for their work. I mean, if you own a business, anyways, there's a lot of things we're thinking through, but just really grateful. We are partnering with Caring Across Generations and with the Meta Fund, and really kind of want to spark a movement around care in California that is intergenerational. So excited to be with everybody today, and look forward to partnerships ahead.
Thanks so much, Rachel. Yeah, Claire, I see your hand up, and then Laura. Claire, you want to introduce yourself?
Yeah, hi, I'm Claire Ramsey. I'm a senior staff attorney with Justice and Aging, and I just wanted to hop in here because of all of the conversation about the master plan for aging. And I just want to say, as someone who works on California policy, how important I think it's going to be to use that to really leverage our thinking in a much more cohesive way. And I think that's already starting to happen. Like we're working with a bunch of partners to really put out a legislative agenda for this year to like really highlight what's happening around older adults and people with disabilities in several different contexts. And I just wanted to flag a couple things that people might be interested in. There is a whole section of the master plan goal that's around caregiving, and the governor's 10-year goal is 1 million high quality caregiving jobs by 2030. And then there are specific initiatives that are supposed to basically kick in the next 2 years. So I think there's a lot of valuable work that can be done about pushing forward on those initiatives in the next 2 years. But I would also say the caregiving initiatives that are laid out are really good as a starting place, but they're not going to get us to where we need to go if we want to see 1 million caregiving jobs that are well paid. So like, you know, there's going to be some committees formed. There's going to be a workforce solutions table that's formed. Right now it seems to suggest it's only around skilled nursing, but I think we need to broaden that table out and really think about the whole care infrastructure. There's going to be an equity committee formed, which I think is another place to really talk about these intersectional issues around who's getting care, who needs care, who's doing the care providing, and really look at that for our state. And then they're also looking to form a newly revised long-term services and supports committee. So I think those are some places. And I just want to mention a couple other things very quickly about access to Medi-Cal specifically. Obviously, that's not the only way people can access care, but it's one of the best ways that we've seen for the state to influence those policies. And so there is a bill to expand Medi-Cal to undocumented older adults 65 and older. It is not out yet, but there will be a bill to eliminate the Medi-Cal asset test, and Justice and Aging is one of those co-sponsors there. There is the California Alliance for Disability and Aging is going to be moving forward on its next step. And I know Josie probably knows all about this, on its next step toward an LTSS benefit that's more universal, somewhat in the Washington model, but to answer some of what people were concerned about, thinking about if we could make it a little broader and how we're funding it. And then also the state's looking to do a mapping and a gap analysis of what exists in the HCBS infrastructure universe in California, so that we really can see where communities might be underserved and where certain geographies might be underserved. And I think that will really help inform how we really take an equity-based approach to expanding and improving the care infrastructure in California.
Awesome. Thanks, Claire. So many opportunities actually to jump in on or to track, to stay engaged on. Thanks for sharing that. Laura, did you want to jump in and introduce yourself?
Hi, good afternoon. My name is Laura Leeson with the Institute on Aging. Thank you to the panelists. This has been fantastic. In the spirit of wanting to pilot new initiatives and figure out how we can be a part of the caregiving solution, the Department of Disability and Aging Services in San Francisco about 4 years ago funded a pilot program that IOA implemented called Support at Home. And it essentially serves middle income San Franciscans who are 18 and over, who can't afford to privately pay for care, but who also are not eligible for Medi-Cal. And we know that there are lots of people disincentivized to spend down to therefore get Medi-Cal in order to be able to provide their care. Two interesting things I want to build upon. So this program serves approximately 200 clients and has a wait list of 300. So I think as we're talking about pilots that we want to consider how we fund, how we try things, there may be an opportunity there. I also want to highlight that UCSF was a third-party outside evaluator, and I think there's always more credibility when we can go back and say, look at these actual tangible healthcare savings. In this case, the dollars were not, kept locally; they were returned to the state and the Fed. But we did see a statistically significant decrease in providing this subsidized home care in falls, hospitalizations, and ED utilization. And I want to encourage piloting and creativity, and also an evaluation that can be comprehensive enough to show us the dollar cost savings, because oftentimes our stories tend to stop when we don't have the data to demonstrate the impact our programs are making. So thank you.
Yeah, and that ties in really well to the point I think Josie was making earlier about being able to test models, prove the value, and spread it from there. Any other ideas or takeaways or things you're starting to think about, grapple with, that you want to throw out into the mix? You have such expertise on this call.
I would like to make a comment.
Yes, please.
Yeah, I'm with the Compassionate Community Care We provide home care to people. Majority of our clients, they are not eligible for Medi-Cal, which is a large amount. Like many of us, maybe when we get older, we may not be eligible for Medi-Cal. We are in the middle. And also I want to echo Laura, which is mentioned about, which is such a great program, Support at Home. I hope they can get more funding and the criteria can be enlarged a little more. Right now, there's a limit, and as you're talking about also 300 people on the waiting list, there are probably a lot more people who need care. Majority of our client that private pay is really sad to hear when people there have a small amount of savings, they're afraid to spend down, and because they're scared what will happen afterwards.
Mm-hmm.
And also we've been experiencing such a hard time to recruit good quality caregivers. And people were talking, we want to get quality caregivers, but not many people get into this field. And I'm just wondering what's the incentive, and some people were talking about that. Yeah, I'm wondering now, because there are people there, I know a lot of people out of, it's kind of sad, a lot of people out of job, but on the other hand is we are in such a shortage of workers because not many people come to this field. They would rather just stay at home. They may get more pay or comparable to stay at home other than come to this field.
Mm-hmm.
So what's the way to encourage them to come here? I'm just wondering, instead of giving people those unemployment or stimulus check, maybe give some incentive. Hey, if you come to work as a home care worker, you get a certain amount as certain benefit. Let's say maybe affordable housing, maybe they can be part of the people. They can, yeah, if you work as a home care worker, maybe you can get access to affordable housing or something, right?
Mm-hmm.
I mean, we want to improve they're like a
excuse me.
Bless you. Like it's a career ladder. On the other hand, is the bottom line is the pay. Yeah, for us is we, in addition to the pay, we pay competitive wage. We also give them like 401k and all that. But on the other hand, it's still not such a high pay job. So how can we make it worthwhile and attract people to come in?
Mm-hmm.
And boil down to that's how people get a caregiver, good caregivers. Because across what I hear from our colleagues, they're all having a hard time.
Yeah. So
recruit a good worker.
Yeah, it's a great point. I'm wondering if Annie and or Heather want to respond to that. You seeing any movement happening around the pay in the care economy?
I think with hi, this is Annie. So with at least some of our major cities that raise the minimum wage to above the minimum wage, right? For San Francisco, it's $17.05. We are still seeing, like for every 16 spaces of training, we usually have about 60 to 80 people wanting to come to the class. But because we have public funding, and that class have very high placement and completion enrollment goals, right? So for people that are coming into the home care field, but from other occupations, and after they've gone through the training, they realize that it's a really hard job. And some, literally say after the training, they don't want to work as a home care worker or work as a caregiver. So we already spend the thousands of dollars to train this person. So I think that if there's a good solid immigration policy for this administration that allow more family reunification versus that previous administration only want to admit people with skills and high education, then we could attract more people to do the caregiving job. Even, not just with home care workers, but also teachers, social workers, right? I mean, we're right now competing with the tech industry because they pay much higher, and the millennials are very attracted to work in the tech sector versus the caring field. So I think that it somehow ties us also closely with the immigration policy. When there's a stoppage of flow of immigrants into our cities, then you have less people going for the caring, because again, all of the speakers mentioned that as a caregiver, you're not highly paid, you're not highly honored, you're not recognized. So until we move all three up, I think that it's going to be still a struggle to try to get many people into the field. San Francisco is lucky because we still draw a lot of immigrants into our city. But if you're in the suburbs or in Fresno or in rural cities, it's very hard to get bilingual, bicultural home health aides.
Yeah,
I would
thanks,
add
Amy.
to that it's salary is a big piece, and it's obviously, I think the minimum wage issues have to get addressed. It's also the quality of oversight and the cultures of the organizations. And I don't think we've paid enough attention to how to improve the cultures where people work, giving them the supports they need, helping them with training, helping them to deal with some of the emotional aspects of it. Counseling and supports, for there's a tremendous amount of grief that goes on that often remains unresolved. And providing those kinds of supports when it's a very lonely job in some respects, and with a great deal of responsibility. And anyways, and whether it's through telehealth or other kinds of ways of connecting, providing a more of a network that can support people who are dealing with these very challenging issues. And training is part of it, but it's taking care of the human beings who are caring for others that I think has to come to the fore.
Yeah, thanks, Heather. When I was taking care of my father-in-law, I thought hospice was going to help more. But the thing that they did, the thing that helped me most was when she said, you might need a massage and you might need to surrender. That was the support, So yeah, it comes in all different ways. Josie, you wanted to add something to this topic.
Yeah, I think, so a few things that have been highlighted already that, recruitment and retention for any particular workforce is not particularly challenging. Pay people well, give them good benefits, and make the job a dignified job that is publicly perceived as professional and important is tends to go a long way. Now, part of that is there's sort of two things that we have to do that's part of that. Part of that is the culture change work, right? This work is centered in devalued women's work, right? That's sort of seen as hidden and invisibilized. So how do we sort of change that narrative in a way that then adds that builds a public perception of value and dignity to the work outside of just pay and benefits, because that's what you're going to get to recruit folks. And then we have to think about not just benefits that are individual, communal, and family sustaining, but we have to think about incentives, which is part of sometimes why I don't always think federal law is the way to go, because there has to be a sense of uniformity in federal law. But how do we build some of these laws in a way that allows flexibility in how we think about incentives, right? I think about there was, tons of vocational schools and trainings in high school and in early undergrad years, right? And if someone would have told me that I worked all through undergrad to pay for my undergraduate degree, and I was looking for the highest paying job. And if if we think about what are those incentives, is the incentive to give the children of care workers free education to their local community college, right? There are different retention strategies and recruitment strategies that I think we should just think about and be open to experimenting and set up those pilots at local and state levels. I think about Hawaii, right, where the secretary of their aging department says, I have money in the bank for the workforce, but I can't recruit people to Hawaii because housing is expensive, and I can't use this state and federal money to say we will pay for your housing if you come to Hawaii, right? So how do we sort of think about incentives in a different sort of way? And then the other thing that I will just say, especially when we're talking about states like California, who have such pride in their Medicaid programs and are doing incredible things when it comes to care, Medicaid is the industry setter for the workforce. Sets the industry standard for wages, for benefits, for training, for certification, right? So there's like a way that we have to talk about wage pass-throughs and how do we increase the reimbursement rate and the wage rates for workers who are paid through Medicaid, which is a majority of most care workers, right? So we have to look at the same way we sort of think about corporate campaigns, right? Like who is the corporate influencer in certain things and how do we strategize with them to set a new standard? Medicaid in tons of our states are the industry setters. So what do we have to do and think about and really influence a Governor Newsom who, you know, has many different political, you know, desires, and how do we sort of say you can be a leader in thinking about your state's Medicaid program to be an industry setter in a different way, to be an experimenter in a different way?
I love I knew that this conversation would be so dynamic because it is all of these, there's so many opportunities actually, when you think about it, there's from the training to pilot testing to influencing, you know, payers like Medicaid, to influencing policy, to changing the culture, to talking with our neighbors, you know, and that's exactly what we were hoping for this session, because you all are coming at this from such different perspectives and you have different strings you can all pull. So hopefully you've heard some ideas that can percolate and maybe you can take some action on them. I know we didn't get to all the questions and there's probably some more that you have, but usually we try to link up questions that folks posted in the chat with the appropriate speakers or funders, and we'll do the Aging Intersections group that design team and I will meet I think on Monday and kind of debrief this discussion and think about next steps. And so we'll keep all of this good thinking in our minds as we move forward together. So thank you so much for participating. A huge, huge thank you for our speakers who did a phenomenal job of preparing and meeting that challenge of having complex information and dialing it down to really interesting sound bites and really important sound bites for us. So many thanks. Good to be with all of you today.
Thank you.
Take care of yourselves so you can take care of others.
Okay.